Good evening, everyone. My name is Chien. I am a breast oncologist here at UCSF. I have been here for over 15 years, and I'm joined tonight by many of my colleagues. And we'll introduce ourselves in a second. I first just want to acknowledge that this is our first breast cancer forum without Dr. Rugo, which feels very strange. And as all of you know, she has moved to City of Hope to lead their women's oncology program. And we've been in touch with her, and she's doing great. And we're so glad and excited to continue the Breast Cancer Forum here at UCSF, where we will not only provide updates after large meetings like ASCO and San Antonio, but throughout the year, there will be other topics and forums around specific topics related to breast cancer. So I want to first have my colleagues introduce themselves. And of course, Melody Galliou, who has been helping coordinate the Breast Cancer Forum for, gosh, was it 20 years almost?
I think this is year 12, I believe,
Okay,
for me.
well,
Yeah.
it feels like you've been here since the beginning, and we are so grateful. So yes, we are so happy to be here. I will let my colleagues introduce themselves. Why don't we start with Dr. Melisko?
Hi there. So I think I've been actually with the forum probably for 20 years. We actually, when Dr. Rugo left, we saw a picture online of us when we used to do this back at Mount Zion. And it was Joe, Melanie, and I when we were all a lot younger and less wrinkly. But anyway, I've been at the Breast Care Center for 23 years now, and I have a significant interest in the study of CNS disease, metastatic disease in general, and also quality of life. And recently kind of gotten an interest in how patients use artificial intelligence to answer questions to get care. And so I'm trying to get a study through the IRB right now, looking at how that impacts patient care in terms of anxiety um, and whether the AI that patients are getting from a very, reputable source is actually giving them the right information. So I look forward to sharing all the exciting stuff from ASCO with you guys.
Thank you. How about Dr. Batra-Sharma?
Hi, everyone. I'm Hemali Batra-Sharma. This is my second breast cancer forum, so I'm grateful to be able to partake. I joined the team last year and have a research interest in triple-negative breast cancer as well as lobular breast cancer, and so looking forward to sharing these updates from ASCO.
Thank you. And Dr. Huppert?
Hi, everyone. It's great to be here. Thank you all for joining tonight. I always love these forums and get such great questions and ideas about where to move things forward. I've been at UCSF since I was a fellow and then joined faculty coming up on 3 years ago now. So I've been delighted to be a part of these. And yeah, research-wise, I mostly work on clinical trials related to novel agents across the 3 breast cancer subtypes, and have a particular interest in CNS disease as well, like Michelle. And really excited to bring novel agents to patients. And so I think it's a really exciting time in breast cancer since there's been so many recent approvals and novel agents in development. And so I think clinical trials are the way that we can kind of get more drugs to patients. And so excited to share the latest advances with you all tonight.
Thank you. And Dr. Mukhtar?
Hi, everyone. My name is Rita Mukhtar. I am the lone breast surgical oncologist here on the forum tonight, and very happy to be here. I have been at UCSF since 2001. I've done all of my training here, and then I joined the faculty in 2016. I lead our lobular breast cancer research program at UCSF and have a strong interest in trials specifically for lobular breast cancer, and I'm currently helping to lead a registry study for metastatic lobular cancer using ctDNA as a way to track disease burden. And later I will be sharing some of the data on ctDNA from the I-SPY trials that were presented at ASCO. So happy to be here.
Thank you. And just a few housekeeping to take care of up front. So you can join our listserv and be updated on upcoming forums. This forum and all forums will be recorded and will be circulated. And please email us and email Melody to let us know about topics you're really interested in. We will certainly do our best to address those. And we haven't yet chosen the next date for the forum, but we'll email that out as soon as possible. So without further ado, I first want to just say for breast cancer this year, it was a big year at ASCO. Not only did we have a number of potentially practice-changing abstracts, we had a plenary abstract that was selected. So really exciting. What we'd like to do tonight is start with our metastatic abstracts. We'll start with Serena-6 in the ER-positive space, looking at ctDNA, and then VERITAC-2, which is looking at a novel PROTAC oral SERD in the metastatic setting. And then we will move on to HER2-positive, where DB09 with trastuzumab deruxtecan in the first-line setting, also potentially practice-changing, and then triple-negative with ASCENT-04, looking at sacituzumab and pembrolizumab in the first-line setting, also potentially practice-changing. So that packed agenda for metastatic disease. And then we will move on to early-stage disease, where we'll talk about the use of ctDNA. There was a lot of abstracts with ctDNA in both the early stage and metastatic setting, but in the adjuvant, looking at the MRD, so minimal residual disease setting, and the use of ctDNA in the DARE study. And then Dr. Mukhtar will present a couple abstracts looking at ctDNA in the neoadjuvant setting that we participated and led here at UCSF. And then last but certainly not least, we'd like to present data from the OASIS trial, which looked at elinzanetant, which is a new medication for hot flashes in patients with taking aromatase inhibitors or hormone therapy for breast cancer. So since we are always short on time, and I also want to add, please write in with your questions. We will do our best to answer them. I don't think anyone can do that better than Dr. Rugo, so we will do our very best to do her justice by answering as quickly as possible. Bear with us. We thank you for your patience in advance, but please do write in with questions. We will do our best to answer them. Okay, so Hemali, do you want to start with Serena-6?
Yeah, I'll share my screen.
Thank you.
Are you all able to see this?
Yep.
Okay, perfect. So I'm really excited to present the results of the Serena-6 trial. This was it's inspired a lot of questions among us regarding our potential treatment paradigm for advanced hormone-positive, HER2-negative breast cancer. So the slides that I'll be discussing were presented by Dr. Turner at the ASCO meeting, and this is a study, phase 3, double-blind, CT-guided, that evaluated camizestrant, which is a SERD, it's an oral agent that's a selective estrogen receptor degrader, in combination with CDK4/6 inhibitor therapy for the treatment of emergent ESR1 mutations while patients were receiving their first-line endocrine therapy for advanced hormone-positive, HER2-negative breast cancer. Just for reference, there was a simultaneous publication in the New England Journal of Medicine on the results of this study, so I've included a little screenshot below. So quick background, the majority of breast cancers are hormone positive and HER2 negative, and the estrogen receptor is encoded by the ESR1 gene. When we see mutations in the ESR1 gene, most often those mutations are acquired as a resistance mechanism. They emerge in response to treatment with aromatase inhibitor therapy. So this trial evaluated camizestrant, which is a next generation oral SERD, and a complete estrogen receptor antagonist designed to inhibit and degrade mutant as well as non-mutated or wild type estrogen receptor. The SERENA-6 study utilized ctDNA testing because we can actually, using that blood-based ctDNA or circulating tumor DNA assessment, find ESR1 mutations. And we had prior studies. There was a trial, for example, called the PADO-1 trial, in which patients who were receiving aromatase inhibitor therapy plus palbociclib were switched to fulvestrant. So there was a switch in their endocrine therapy upon the detection of the ESR1 mutation ahead of actually seeing disease progression on scans. And that had shown significant improvement in progression-free survival compared to the continuation of aromatase inhibitor plus palbociclib. So camizestrant, in prior studies has shown improvement in progression-free survival in comparison with fulvestrant for patients with advanced ER-positive advanced breast cancer who have been pretreated. So that's the groundwork for the SERENA-6 trial. They tested the hypothesis that using camizestrant to treat the emergence of an ESR1 mutation, even before patients actually were diagnosed with progression on scans, they tested the hypothesis that doing this change could extend the duration of benefit of the first-line treatment. So what they did is they actually screened, 3,000 plus patients on their first-line aromatase inhibitor plus CDK4/6 inhibitor therapy. That's usually our first-line standard of care approach. And patients had received that first-line treatment for at least 6 months. And they utilized the Guardant 360 ctDNA blood-based assay to assess for the emergence of an ESR1 mutation. They performed that testing every 2 to 3 months during that kind of initial screening surveillance period. Among those 3,000 plus patients, they found that 548 were found to have that ESR1 mutation. And interestingly enough, just over half of those patients had a positive ESR1 mutation on the first test. So after they, detected the ESR1 mutation, they randomized 315 patients onto the trial. And this is the study design. So it was a phase 3 randomized double-blind placebo-controlled study. And they enrolled patients with advanced ER-positive, HER2-negative breast cancer. As I mentioned, all patients had previously been on their aromatase inhibitor plus CDK4/6 inhibitor therapy for at least 6 months. And they had that ctDNA evaluation showing the emergence of the ESR1 mutation. And importantly, patients did not have any evidence of disease progression on their scans. Because right now, how do we determine who switches therapy? We look at a scan, we determine, whether someone has progressed and then move to the next line. So patients here had molecular progression, so a change in that ESR1 status, but not having had radiographic progression on scan. They randomized the patients 1-to-1. So one group received the camizestrant and continued the CDK4/6 inhibitor. They received placebo, essentially in order to create the double blinding and placebo. They had a component of placebo therapy for each of the arms. But essentially, we're looking at a comparison of camizestrant plus CDK4/6 inhibitor versus aromatase inhibitor plus CDK4/6 inhibitor. And their primary endpoint was looking at the progression-free survival by the investigator assessment. Just briefly looking at patient characteristics, median age was around 60 years. Majority of the patients were white and postmenopausal. Around 42 to 45% of patients had visceral or organ involvement of their metastases. The 62 to 63% of patients had been on aromatase inhibitor plus CDK4/6 inhibitor therapy for 18 or greater month period. When we look at the investigator-assessed progression-free survival, there was a significant improvement in the PFS. The median PFS was 16 months in the camizestrant plus CDK4/6 inhibitor arm versus 9.2 months in the AI plus CDK4/6 inhibitor arm. So if you see here at the 24-month mark, when they followed patients out, roughly 30% of the patients in that camizestrant plus CDK4/6 inhibitor therapy did not have progression versus 5% of those patients on the aromatase inhibitor plus CDK4/6 inhibitor arm. When they looked at the breakdown of patients, they looked at certain features to see, how did the trend differ in terms of favoring the camizestrant plus CDK4/6 inhibitor treatment. And you see overall, regardless of what feature they looked at, there was a favorable finding in the PFS improvement with the camizestrant and CDK4/6 inhibitor therapy. They also looked at quality of life, and this is really important for us to think about as well. Time to deterioration in global health status. This was a composite of factors looking at quality of life while patients were on treatment. And they did also see improvement in the global health status and quality of life in the patients receiving camizestrant plus CDK4/6 inhibitor compared to the AI plus CDK4/6 inhibitor. So that they looked at that median time to deterioration, and it was 23 months with camizestrant-based therapy versus 6.4 months with the AI-based therapy. They also looked at the second progression-free survival, and of note, the data for this were not mature. We certainly need longer-term follow-up. So right now, the data don't meet the criteria for statistically significant improvement, but numerically, there were fewer PFS2 or second progression-free survival events with the camizestrant-based treatment versus the AI-based treatment. In terms of safety, so a small percentage of patients in both arms had any serious adverse events, so roughly 10% in the camizestrant group versus 12% in the AI plus CDK4/6 inhibitor group. Very low rates of treatment discontinuation in both arms, roughly 1 to 2%. And then when we look at the median treatment exposure in the camizestrant plus, when we look at the median treatment exposure to endocrine therapy, there was longer exposure to endocrine therapy in the camizestrant group, 10.1 months versus 6.3 months with aromatase inhibitor. And then when we look at time to the median treatment exposure in terms of months on the CDK4/6 inhibitor as well, you see that the camizestrant plus CDK4/6 inhibitor group had a longer treatment exposure to that, 9.8 months versus 6.1. When we look at the adverse event breakdown in terms of the most frequently noted adverse events in 10% or more of patients, the most frequent events in the camizestrant plus CDK4/6 inhibitor group were neutropenia, anemia, and leukopenia. And that really reflects the toxicity that we commonly see among the CDK4/6 inhibitor treatment. They did comment upon photopsia. So photopsia is brief flashes of light in the peripheral vision. And the majority of those events were grade 1. They did not impact the daily activities of the patients who experienced that symptom. And if the patient reported that symptom, the visual effects had no or minimal effect on their functioning and did not have structural changes in the eye or changes in their actual visual acuity. So overall, we saw in this trial that switching from the aromatase inhibitor to camizestrant while continuing the CDK4/6 inhibitor therapy, guided by this, with this decision guided by the emergence of ESR1 mutations during that first-line treatment before patients had disease progression on scans, led to a significant improvement in progression-free survival. And that progression-free survival was consistent across the subtypes of CDK4/6 inhibitor therapy and the different subgroups. There was also an important delay in the time to deterioration and quality of life with the camizestrant plus CDK4/6 inhibitor therapy compared to the continuation of the AI plus CDK4/6 inhibitor. And overall, there were low rates of treatment discontinuation due to adverse events. There are some caveats and questions, and actually I'll go back to the former slide in just a moment, but we bring up this question of how our potential treatment paradigm may be impacted by these results. Would this treatment strategy improve overall survival among our patients? Would that second progression-free survival, that PFS2, be a good surrogate for overall survival? And some of the things that we have to think about are that, one, there is a lack of crossover to the camizestrant in the control group. So, for example, right now, as I said, our current treatment paradigm is we do the first-line treatment At the time of radiographic progression, so progression on scans, we assess for the ESR1 mutation, or we assess for other targetable mutations, and then we decide the next line of therapy accordingly. And in this trial, there was a change in that hormone therapy or the endocrine therapy before radiographic progression. And then upon progression in the control group, there wasn't a crossover to camizestrant. So that prevents the direct comparison of the strategy of switching here at molecular progression as per SERENA-6 versus switching to camizestrant plus CDK4/6 inhibitor at the time of radiographic progression. There's also a consideration that post-progression treatment being different between the arms can also impact longer-term outcomes potentially. So when we looked at the group who had received the camizestrant plus CDK4/6 inhibitor therapy, upon progression, around 60% of the patients received endocrine-based therapies, either a monotherapy or a combination therapy with other targeted agents, and 46% of those patients had received chemotherapy after receiving the camizestrant plus CDK4/6 inhibitor. And when you look at the control arm, after those patients had received aromatase inhibitor plus CDK4/6 inhibitor treatment, when they progressed, around 70% of those patients received endocrine-based therapies, and roughly 35% had received chemotherapy or antibody drug conjugate therapy. It's important to think about how 14% of the patients in the control group had received an oral SERD, so selective estrogen receptor degrader, either alone or with targeted therapy. And that's with the presence of the ESR1 mutation, which is designed to be targeted by this type of oral therapy. So I think these details really truly matter because they will inform the longer term outcomes of patients and impact how we translate these findings to our clinical practice. And finally, we need to think about the burden of increased ctDNA monitoring. So as part of the trial, they had done ctDNA testing every 2 to 3 months. And currently in most of our practices, we assess for ctDNA assessment of targetable mutations, usually at the time of progression. We don't subject patients who are responding to a certain line of treatment to just serial ctDNA monitoring. And this does have a potential impact on patients, and can also impact our health system. The burden of this testing has multiple implications. And so a lot of questions generated by SERENA-6, and I appreciated the question raised by one of you before this forum. How are we going to, if we get FDA approval for camizestrant, how would the results of this study impact how we approach treatment? I think these broader questions really play a role in my answer. I would certainly want that longer term follow-up. And then I think we need to think critically about how the ctDNA monitoring would impact the health system and patients. And then does the acting upon molecular progression translate into long-term improvement in overall survival for our patients? So I'll pause there. I know that there will be lots of questions. I'll stop my screen share. Oh, I think, Joe, you were speaking, but...
Thank you so much, Hemali. That was really a great summary of a big presentation. And, this was selected as a plenary because it really represents a paradigm shift. This is really asking the question, should we be changing therapy based on ctDNA mutation detection before clinical progression, right? We all know right now we are changing therapy with scan results, progression on scans. If we change earlier because of molecular progression, will that help patients in the long run? And it's not surprising, right, that we would see improvement in PFS1 when you detect a mutation that says that the tumor that is resistant to the treatment. And so the real question is, what about the line of treatment after that first switch? And then the line after that, right? And so I guess I want to ask our other panelists, what are your thoughts about these data, right? I'm sure many people have been asking you since the presentation. Laura, what do you think?
Sure. Yeah. So I think, yeah, Hemali did a fabulous job summarizing the key issues here. I think that, as Hemali mentioned, it would be very paradigm shifting to switch treatment based on changes molecularly that we're not seeing on imaging. And, historically, we've always wanted to continue each treatment as long as possible and not switch too early, because if you switch kind of too early, then you potentially run through options. And so we've wanted to kind of extend each line as long as possible. And so this would be a different approach, right? If we see a mutation, should we sort of switch proactively before we see an imaging change? And will that help people, eventually stay on this longer? And so I think that is kind of the key question here. I think the issue potentially is that the way that the study was done, there was not, as was mentioned in the chat, kind of direct crossover to get the question would be, does it help to switch earlier, or can you wait and switch after? And so it's not exactly designed to answer that question, because those that didn't switch didn't necessarily get Canny as the next treatment. They could have gone on to get other treatments. And so what we're ultimately talking about as this PFS2 is we're basically comparing the time on first line therapy and then the switch to Cami versus what they got their first line treatment and then their second line treatment. And in a way, the treatment after the switch to Cami, it's almost like a third treatment, right? So they've gotten the switch to Cami and then they also get the next treatment. And so the comparison between the three treatments in a way versus two treatments, it's a little bit difficult potentially to evaluate. What we ultimately want is to see overall survival. Does that earlier switch help people live longer? And it'll take a really long time to figure that out. And not all of the treatments that patients around the world have access to will be the same. And so I think it's hard to sometimes see that. And so ultimately, I think it just leaves us a little bit, confused at the moment of how to enact this data until we get a little bit more follow-up, until we have a better sense of that. How do patients do on their next line of treatment? How should we be comparing things? Is that quality of life signal real? If it's true that patients, if they switch, they have much better quality of life, is that a good enough reason? Even if it doesn't ultimately prolong survival, if quality of life is better, that's very important for our patients also. And so I think it left me having a lot more questions than answers at the moment. And definitely we'll see more to come from this trial with longer follow-up. And certainly we'd be very excited if it does turn out that switching early helps people stay on it longer. So I think it's a really interesting idea, but I think at the moment, I'm not thinking, it's not obviously yet approved, but even if it were to be approved, I think we just want a little bit more information first before we kind of make this prime time, in my opinion.
Thank you. Michelle, what do you think?
Yeah, I mean, I fully agree. I mean, I've already had several patients reach out to me asking if we can start doing this. And, we see, this is harkening back to, I think, actually probably the only one who was on faculty at the time when the original cell search data came out, with looking at cell-free or looking at circulating tumor cells rather than cell-free DNA. They, really looked at this concept of changing therapy before there was radiographic evidence of progression. And obviously, we're doing a lot more elegant trials now looking at PFS2, but it seems very appealing to, jump on things and make a change when it looks like the cancer might be progressing at a sort of subclinical, subradiographic level. But really what we could end up doing is, making the cancer more resistant. We could be burning through treatments faster. So I think it is very promising, but I personally will not be jumping on this right away. I feel like we do need to see more mature PFS2 data. I don't think that we need to see overall survival data. I mean, we've seen that, inavolisib and several other drugs have been approved recently. Dato-DXd was approved without survival data. So there's been a recent it seemed like, the FDA was moving in the direction of only approving new drugs for breast cancer if there was a survival benefit. But, things are so busy in the breast cancer space and so much can happen, so much variety beyond when a patient is on a trial, what happens in their second line, third line, fourth line. And we'll talk about this, in the next presentation about, Veritech and, the patients. We don't know if the patients that were on the AI plus AI that went on to second line when they had radiographic progression, did they all get a biological targeted therapy or did they just get Faslodex? What did they get? And that data is probably there and available, and it will be dug into and presented in more detail later.
Thank you.
We could probably spend the entire
I know, we have to move
talking about
on
this
because
one,
it's already
so should we move
6:30.
on to
But
the
it's a
next?
great segue to the VERITAC-2 study that Dr. Melisko will present, because that is another novel oral SERD approach.
Right, and let me just pull up and share my screen. Oops, sorry, I have the wrong one up there. And I want to start off by saying that I had, when I was originally listening to this, I had been pronouncing it vepdegestrant, and realized I had my pronunciation completely wrong. So I feel feel now that we know that it's pronounced a different way. But for those people in the audience that were asking about how to say that they were hoping that we could use the brand name. So far, this does not yet have a brand name, but it's being called Vepdig. That's, I think, how they pronounced it at the meeting. So we can henceforth call it Vepdig. So as to get things rolling, I think Hemali introduced the fact that there's really no established consensus about what to do after a patient has progressed on first-line endocrine therapy. We heard in the Serena-6 trial that there's this idea or concept that we should be following molecular changes to potentially change to a novel SERD. What this trial did was actually randomize patients up front after they had progressed on a first-line endocrine therapy to receive either Vepdig or fulvestrant.
Michelle, are you showing slides right now?
Oh, yeah. Is
I'm
that
not-
not showing?
no.
It says I'm screen sharing.
Unshare, and then open your slides and then share again.
Oh, okay. Stop share and start. Sorry about that. See if I will. Is it doing it now?
Yep.
I should have asked right from the beginning, and I'll switch it over to slideshow. Okay, is it not, it's not going to slideshow, but hopefully we can see, can people see it okay now? Okay,
You can, do you want to,
I'm trying to put it
do
into slideshow. It's not going
Presentation mode though.
here. There we go. Is that, do we
Yep.
see it as a slideshow
yeah,
now?
that's good.
Okay, I'll go back to
Wait.
again. Nope, geez. Okay, there we go. Okay, hopefully we all have it now. Okay, so going back to, as I was saying with the background, so Vepdig is a selective oral PROTAC, which is a novel class kind of related to oral SERDs, but slightly different in the way that it degrades the estrogen receptor, and it targets both wild type and mutant estrogen receptor. And so this has already been studied in phase 1 and phase 2 trials, showing that it's well tolerated and has activity. And for those of you, there may be even people in the audience who had participated in some of our phase 1 and phase 2 trials. This drug was previously known as ARV-471. And so the phase 3 trial randomized patients who had received one prior line of therapy with an endocrine therapy plus a CDK4/6 inhibitor. And then they could receive at least, some received one additional line of endocrine therapy. They could not have received a prior oral SERD, so fulvestrant or elacestrant, and no prior chemotherapy in the advanced or metastatic setting. And patients were randomized 1-to-1, and they were stratified by their ESR mutation and whether or not they had visceral disease. The patients see here, there were two groups that were analyzed, those with an ESR mutation, and then they also looked at all patients. And the majority, almost 80%, were postmenopausal. And this was an interesting trial because it was sort of equally divided between occurring in the United States and other parts of the world where there was a fair representation of Asian patients. You can see over here that 80% of the patients had received only one line of prior therapy in the metastatic setting, and about 20% had received 2 prior lines, and all had received a prior CDK4/6 inhibitor. One of the things that's important about this is that comparing this to something like the Emerald study with elacestrant, much fewer, many fewer of those patients had received a prior CDK4/6 inhibitor, whereas 100% of these patients had, and a high percentage of these patients had liver mets or visceral disease. And so to cut to the chase, just a very straightforward trial design. The BICR stands for blinded investigate or blinded clinical review. And so what we saw here was that patients that were randomized to vepdeg had a median progression-free survival of 5 months versus 2.1 months. This is for patients with ESR mutations, so over a doubling of median time to progression, and that was highly statistically significant. Looking at patients that had, sorry, going back, just skipped over the patients that did not have an ESR mutation, so the wild type, there was no difference in median progression-free survival between vepdeg and fulvestrant. You should notice that in the patients without an ESR mutation, the fulvestrant arm did a little bit better than they did in those patients that had an ESR mutation. Now, and me trying to, get rid of the injections for patients on fulvestrant, we were hoping that we would actually see an improvement with vepdeg across all patients, including ESR wild type, but unfortunately we didn't. It's unfortunate also that probably the FDA will not approve this for patients without ESR mutations, even though it's probably better tolerated for patients. This is a plot that shows that the benefit was seen across all types of patients older than 65 and younger. Sometimes the confidence interval does cross 1 if it was a small group of patients. You can see here that the confidence interval is wider when it's a small group. Particularly down here, when you're looking at 2 lines of therapy, there weren't very many patients in either of the arms. And so, but across the board, vepdeg did seem to be superior to fulvestrant in ESR1 mutations. Overall survival data is not yet mature, so only 20 and 22% of targeted events, so we don't know anything about overall survival from this study. Clinical benefit rate, which represents the partial responses and stable disease for greater than or equal to 24 months, was higher with vepdeg as compared to fulvestrant, so almost a doubling of clinical benefit rate in patients with ESR mutations, and actually a tripling or a quadrupling of the ESR or the overall response rate with vepdeg compared to fulvestrant. So, clearly for people who do respond, they can get, a very robust response. Looking at all patients, there was still a numerical benefit with vepdeg over fulvestrant, but in the clinical benefit rate, it was not statistically significant. There was a statistically significant overall response rate with vepdeg across the board, but overall survival was not. Clinical benefit rate was a secondary endpoint. Looking at safety and tolerability, vepdeg seems to be very well tolerated. There was numerically a higher rate of grade 3 adverse events with vepdeg as compared to fulvestrant, with a higher number of patients having, although very small percentage, leading to treatment discontinuation or dose reduction. The main difference that we see is a higher rate of fatigue with vepdeg against, any grade 25% versus 16% with fulvestrant. I was actually surprised to see that the differences in nausea were so small. I would say in my own personal experience, I've actually seen in patients on trial perhaps a little bit more GI toxicity, more nausea. And then another interesting thing that we've seen with this vepdeg when given alone and in combination with other agents, because we're studying it, Dr. Chien is the PI at UCSF of a trial looking at this agent with other targeted therapies, is that it does seem to be associated with more neutropenia, which is interesting because we wouldn't expect a single agent endocrine therapy to have such a high rate of low blood counts and neutropenia specifically. It also was associated with more decrease in appetite. One of the things that comes across in many of these oral agent studies is looking at the QT interval. So patients participating in the trial had to go in and get a lot of EKGs, and they did not find a significant or substantial QT prolonging effect. So the conclusions were that vepdeg was the first PROTAC to be evaluated in a phase 3 trial, and it did demonstrate a statistically significant and clinically meaningful improvement in progression-free survival. Overall survival is immature, and there was a favorable safety profile where very few patients actually discontinued or had dose reduction of the drug. So this was also shared at the same time in the New England Journal of Medicine. And we would expect action on this drug from the FDA probably by the end of the year, maybe even in the third quarter of this year, maybe sooner. So we're excited about this novel agent. One of the biggest issues, I think, is that we are much more interested in combination therapies than using this agent, I think, and many of these agents as a single agent. And so many of the patients are going to be asking about this. I think it may be a great maintenance therapy, but I'm not sure. I would like to wait a few more months to see if we can get more combination data. Similar, like in the Elevate trial, we're studying elacestrant with a bunch of different agents like abemaciclib, ribociclib, and I know, we're anxiously waiting to see the safety data for the combinations. So that's a short and sweet on that one. Try to catch us up.
Thank you, Michelle. So, this is a very competitive and crowded space, right? Where there are a lot of oral SERDs, novel endocrine therapies, third generation SERMs and SERCAs, complete estrogen receptor antagonists. And so I think one question is, what's the future of these drugs in non-mutant populations? Arvinas has closed their frontline, phase 3 trial, focusing on the late line because of the ESR1 mutant positive data, but not in the all comers. So do you think that, what are your thoughts about using these drugs in a non-mutant population?
Yeah, I mean, as I said, I'm really, I think it's sad and unfortunate that probably the FDA won't approve them, at least in the single agent setting. But as we know from, from the Emerald trial, similar thing happened. They saw similar outcomes with the oral SERDs and and Faslodex, in the wild type population or normal non-mutated population, and the FDA didn't approve it. It only approved it in, patients with mutations. However, all these companies are trying to study it in combination and hoping that maybe they can slip it through in combination. So I think that's probably what's going to happen, is that maybe the FDA will, maybe the drugs will play better with drugs like abemaciclib or something like that, and you'll see an improvement in outcomes in the wild type population when added to another biological and targeted therapy. I think patients are screaming to have more oral options, but these drugs are very, very expensive. And when you do combine the oral agents, both in the ESR mutated and the wild type patients, you see more toxicity with combinations, more neutropenia, more nausea, more GI toxicity. So it's going to be interesting to see how all of them are going to be approved, both for ESR and for wild type patients. I think the FDA is going to be very picky about approving them across the board, though, for wild type. It's going to be very expensive to be able to offer these to everybody.
Yeah, and it's, I think we all can agree that the oral SERDs are very well tolerated for the most part. And we know that they are active drugs, right? Even if we're not seeing that they're superior to AIs. And so what are your thoughts about bring this into the early stage space, where many of them are entering into the adjuvant space, going head to head against AIs? I think that my hope is that even if we don't show that it is better, that if it's better tolerated, that could be an approval path. It hasn't historically been, but it's an important endpoint, and patients can't benefit from drugs that they can't tolerate. So it's really interesting that this is obviously being developed in the metastatic space, showing the best activity in the mutant resistant population, but also wanting to develop it in the treatment naive in the early stage space. And when we know it's better tolerated, and the hope is that there potentially could be a space for it in non-mutant, just because of better tolerability.
Yeah, I mean, I think it's interesting because of course we would love to see in the early stage like a direct head-to-head trial of an oral SERD compared to an aromatase inhibitor, but I don't know if any company has the, fortitude, to do a trial of 10 years, right? Most of the trials of studying these oral SERDs are switching trials where, like Elegant, like, these are trials where patients are starting off on whatever endocrine therapy and then switching if there's, if they're high risk or they have positive ctDNA. It's going to be a long time, I think, before we can start a patient. What will be interesting is if we see something like Elegant or Ember. These are trials where patients start on an aromatase inhibitor and then switch to an oral SERD. If those are positive, will we then feel comfortable starting to use oral SERDs upfront as an alternative, to tamoxifen? I think that's going to be $1 million question.
Well, we know they're very active, and very tolerable. So I do hope that there's a path for them. Let's move on because we have many things to cover and it's already 6:49. Dr. Huppert, Laura, can you share the DB09 data for HER2 positive disease?
Okay, sorry about that. Here we go. Perfect. Can you see my screen?
Yes.
Perfect. So I have the privilege of discussing two different abstracts today that I think the broad summary of both is antibody drug conjugates are a class of medicines that are similar to chemo but more targeted. And the way I often explain it is it's an antibody directed at something on the cancer cell linked to a cytotoxic chemo particle. And so the idea is it's basically pulling the chemo where it needs to go better. And this class of medicines has really transformed breast cancer across all three subtypes. And we now have 4 approved with many, many more in development. And often we approve something, in the second line setting, for example, and if it works better in the second line, one big question is, should we move it earlier? Should we move that drug into the first line setting? And so both of the abstracts that I'm going to discuss today are essentially asking that question, one in HER2 positive breast cancer and one in triple negative breast cancer, is we have these great drugs that are approved in a second line setting, should we move them forward? So the first abstract I'll discuss today is with the drug T-DXd, also called Enhertu, with pertuzumab or Perjeta, comparing that versus THP, paclitaxel, trastuzumab, pertuzumab, for patients with HER2 positive first-line disease. So basically this trial enrolled patients who had metastatic or stage 4 HER2 positive breast cancer. And they had to be treatment naive, meaning they haven't yet seen any treatment for their metastatic disease. This is their first treatment for metastatic disease. And they had to have been off of the prior treatment if they had early stage disease for at least 6 months. And they randomized patients 1:1:1 to receive our current first-line therapy, which is THP, versus T-DXd and placebo, or T-DXd and pertuzumab. So patients were randomized between these three groups. One important point is that in this trial, and the way that we often give THP is we give an induction strategy where you give a certain number of cycles of a taxane, often 6 to 8 cycles of a taxane, so for 3 to 6 months. And then if patients are responding well, you can drop down to a maintenance strategy with the HP and add endocrine therapy in that setting. And one thing that was a little bit different between these arms was the THP arm did that induction maintenance strategy, whereas both the T-DXd and placebo and T-DXd and pertuzumab arms did not do it that way. They sort of did indefinite treatment with those agents. And they followed these patients out over time. And the primary endpoint was progression-free survival. So how long were patients on the drug, basically, and then secondary overall survival and some other efficacy measures. And I should mention that in this particular analysis, the T-DXd plus placebo data is not yet mature, meaning we need a little bit more time to follow up. And so this particular abstract was just comparing these bottom two, T-DXd pertuzumab versus THP. So these patients, there were about 380 patients in each group. They were well balanced between each group. About half and half were hormone receptor positive, HER2 positive, and versus hormone receptor negative, HER2 positive. A high number of these patients had de novo disease, meaning they hadn't had early stage breast cancer that relapsed. Instead, they were stage 4 off the bat. So that's something that's a little bit different than many of our patients that we see in clinic. And then about 6% of patients had brain metastases, and they were allowed to go on if they had stable brain metastases, meaning they were treated with radiation or surgery before going on. And so this is the primary endpoint, so progression-free survival. So a really impressive difference between these two arms, 40.7 months. So over 3.5 years, basically, with the TDXD plus pertuzumab arm in dark blue, versus the standard of care right now is the THP was 26.9 months, which was statistically significant. So a dramatic improvement in those two arms by almost 15 months, which was really impressive to see. Looking at different subgroups, it kind of basically worked across the board. When you look at these graphs, favoring TDXD is to the left of this arm, and you're looking, are most of them over to the left, or is there anything over to the right? Sometimes if it's crossing the line, if you have to see how many patients, is it a smaller, the smaller number of patients, the more variation you have. So the only one that really crosses over that line here is age greater than 65, but there was a smaller number of patients. So I think a little bit, possibly due to that. But in general, across all of these different groups, favoring TDXD plus pertuzumab. And the response rate was higher also. So more patients getting to what's called a complete response with TDXD and pertuzumab versus the THP. The overall survival is not yet mature. So we still need longer follow-up basically to see if patients actually survive longer by moving this first. One thing that Dr. Batra-Sharma talked about was one thing surrogate for overall survival is PFS2. So if it's going to take a long time to get survival, but can we at least look at how people are doing, adding up their first and their second line and seeing if moving it first works better? The PFS2 is favoring the TDXD pertuzumab arm. I think one challenge though is this was an international trial. So again, the same issue where not everyone had access to TDXD in the second line. So if you look at what treatments patients got in the second line, not all of those patients got TDXD next. If you really want to answer the question, you design it so you switch the order and see if you do THP versus TDXD and then vice versa, which one's better, right? But that's not how this particular trial was designed. And it's often actually hard to design trials like that internationally because if the agent's not available locally, the expense can be really challenging. So it can be a challenging thing. I think more and more trials are hopefully allowing for that, because I think it does help us kind of answer the question better and get access to those drugs around the world too for those patients that are in the study. But I think that does make it a little bit harder sometimes to kind of, fully analyze the PFS2 in that setting. And then in terms of side effects, we know really new signals with side effects than what we already know about this drug. TDXD tends to cause more fatigue, more nausea, and there's a risk of interstitial lung disease or lung inflammation in about 11 to 15% of patients on this drug that it's really important to monitor for. On this trial, it was 12.1% of patients had that lung inflammation. Important to try to catch it early because we have some data now that you can try again if you catch it early enough and it gets better. But unfortunately, there were 2 deaths on that arm related to the pneumonitis. So really important, again, to monitor for that symptom in these patients. So I think the key takeaways from this trial is the TDXD and pertuzumab arm demonstrated a significant PFS improvement, and the safety data was consistent. I think there were still a lot of questions or challenges that came out of this, though. I think on first pass, you'd think, wow, this is amazing. We should approve it tomorrow. And I think it will definitely likely get approved on this. But I think 2 important things that we need to think about are, number one, the induction maintenance strategy is really appealing for our patients, right? To say you can do 6 to 8 cycles of chemo, and if you do well, you can go on this maintenance strategy for potentially a long time. And we now have data that we can even add, palbociclib or other endocrine therapy maintenance to make the maintenance even better. And that's not exactly how this was designed, right? So there was a maintenance in the THP arm, but there was not a maintenance in the TDXD pertuzumab arm. And so I wish often that, they had designed it with an induction maintenance similar strategy. There's an ongoing trial called the Demether trial that's looking at that induction maintenance for the TDXD. So we'll have a little bit more information about that over time. But I think one question for us, if this does get approved, is should we do the TDXD indefinitely? But that can be sort of hard in terms of side effects. Or should we use an induction maintenance, and would the induction maintenance work as well? And so I think that's one big question that came out of this abstract. And then I think another question is sequencing. If we move TDXD first, which we know works really well, what should we use next? And would it work as well to do THP and sort of save TDXD for after? Like we still don't know for sure the right order of operations, and if every single patient needs TDXD upfront. I think I'm particularly enthusiastic for using this right now for people that have a significant burden of brain mets, because we know that TDXD gets into the brain well, or if they have a larger burden of disease or visceral disease that we want to shrink things down. I think this is just such an effective drug that I think we can try to get this sort of off-label in the moment for sort of patients that have those higher risk features. But I think we'll have to see if it eventually gets approved, like how we'll end up applying this, whether we do the induction maintenance and whether every patient should get this first or whether a certain subgroup of patients. So more follow-up data will kind of help inform us as we get additional data that's read out from this trial at upcoming meetings.
Thank you. I mean, this really is a huge trial. This was a late-breaking abstract. So what that means is that the data are, the deadline for ASCO abstracts is in, I think it's late January. And so you can submit a placeholder as a late breaker, knowing that as the events come in and they're doing their final analysis, it may not mature until March or April. And this sort of came in sort of just under the wire. And it as Laura said, this is practice changing. And I guess my question is, assuming this gets approved, what are you going to do in the clinic? Are you going to stick with the continuous treatment, or will you give some kind of induction?
Yeah, I personally think that the induction maintenance strategy is very appealing for our patients, because if we can get patients into a great response after 6 to 8 cycles, we don't know what the right number of cycles are, and then patients can go on a maintenance where they're not coming in every 3 weeks for IV chemotherapy. At least they're still coming in for the Herceptin Perjeta, but they're not having all of the side effects, the nausea, the fatigue, the risk of ILD, and you can sort of avoid that and have a long time on maintenance. I think that's really appealing. And potentially, if someone's on maintenance for a long time, could you even re-challenge them with if they do have more disease again, can you go back to the TDXD? I think that would be a really nice strategy in terms of quality of life to have that. We don't know if it'll work as well, but I think the hope is that it could, and we just need to study that first.
How about you, Hemali?
Yeah, I think for me, it'll be interesting to see the monotherapy, the TDXD improvement to really address this question of, what is the additional value of the pertuzumab in this combination, and to see, okay, ideally, we would be able to, in future trials or studies, look at, okay, what Laura just mentioned, where could we do this kind of induction and then have a period of maintenance, potentially even re-challenge with TDXD in the future, kind of minimizing the amount of time on TDXD if we need to, if we can, for certain patients, teasing out a strategy of allowing for some period of maintenance with that first-line treatment. Or if we can just say that continuing this, obviously here, the results show profound duration of time on the first line treatment and improvement in the PFS. So I think it's kind of figuring out how to right size the treatment for that first line therapy for our patients. And I think for me, it'll be really important to see that TDXD monotherapy data.
Yeah. And, you can't argue against that PFS data, right? That looks incredible.
Oh, yeah.
I think one additional reason to do an induction strategy is the risk of ILD. And while it's 15% grade, mostly grade 1, grade 2, low for higher grade, but one thing to think about is if the patient develops ILD, early, then it affects what we can give them later. Most trials are excluding patients who have had a history of pneumonitis or ILD. So it can be limiting for future options. And so we can limit the exposure up front. That would be really helpful. All right, let's move on to triple negative. So Laura's going to do that too. Let's do more shorter versions as we.
I'll go faster
30
this one.
minutes left. Yes, and we're going to.
Perfect.
Yes.
So yeah, the basically same idea as the last trial. Let's take a drug that's approved and works well in the second line and move it to the first line. But this is the triple negative version of that. So this is a trial called ASCENT-04 that looked at moving sacituzumab govitecan or Trodelvy with pembrolizumab versus right now the standard of care is chemo plus pembrolizumab into that first line setting. So these are patients with metastatic disease who are PD-L1 positive. And this is looking at their PFS on that first line of treatment. The patients were relatively well balanced between the two groups. And then these are the PFS data. So 11.2 months with SG plus Pembro versus 7.8 months with chemo plus Pembro. So, again, remarkable difference. We can't get as high of PFS numbers in general yet with triple negative. So these numbers are obviously lower than what we just saw with HER2 positive, but for triple negative, getting close to a year on their first line of treatment is a remarkable advance in this setting. And so this is definitely practice-changing data as well. And one thing I think that's important is that if you stayed on it, you really stayed on it. Many of these patients stayed on it for more than a year. Almost half stayed on it for more than a year. So that's really impressive. And then again, across the subgroups, generally favoring the combination of SG plus Pembro over chemo. Overall survival is still not yet mature. One thing that was really nice about this study is they did allow crossover to SG. And so we will be able to look at that PFS too with a little bit more certainty on this study. And then the AEs were sort of similar to what we know about these agents, diarrhea and low blood counts being common things that we watch for on sacituzumab govitecan, and then watching for autoimmune side effects on the pembrolizumab. So the key conclusions here were that this was a practice-changing trial. It statistically improved the PFS, and this will likely also be approved as a new first-line option for triple negative that's PD-L1 positive. There's a couple other ongoing trials looking at first-line sacituzumab govitecan by itself for triple negative that's PD-L1 negative. There's another trial looking at Dato-DXd, another ADC for metastatic first-line triple negative. So I think more to come this year with other exciting trials for triple negative disease, which has been an area of unmet clinical need. So I think a really important advance for our patients.
Absolutely. And, sacituzumab and pembrolizumab is also being studied in the post-neoadjuvant setting, right? So anytime we see a great drug with great signals in the metastatic setting, we want to bring it up even earlier to see if we can increase the rates of cure. So there are a couple studies, a phase 3 study, really randomizing patients in the post-neoadjuvant setting who we know have higher risk of developing metastatic disease and testing this combination. So really exciting to see advances in the triple negative space, which historically we have had fewer options. So let's move on now to the early stage setting. And there were a lot of ctDNA abstracts presented that were really interesting. We're going to start with the DARE study, which is adjuvant ctDNA use. Michelle is going to present that.
Okay, I've got my screen ready, everyone, this time. So can everyone see this one?
Yes.
Okay, I'm not going to be able to go through this quite as quickly as Laura did, but this was presented by Lajos Pozdai, who's a collaborator of ours in iSpy, and presented on behalf of the DARE investigators. So just to go over things quickly, and I think we've talked a little bit about the purpose of ctDNA as a way of monitoring the possibility of a sort of subclinical recurrence in the adjuvant setting, so detecting a relapse before it's clinically apparent on scans. And then ctDNA is also being studied in the metastatic setting as a way of potentially tracking the disease, almost like a tumor marker, so that potentially patients might be able to get away with fewer scans. And so this trial was focusing on early stage patients receiving endocrine therapy to determine the rates of ctDNA positivity in an ER positive, HER2 negative population, and then to actually evaluate if a patient did have positive ctDNA, what was the chance or what were the rates of them having imaging detectable metastatic disease. Because one of the concerns is that, yeah, if a ctDNA test is positive, but the patient already has radiographically detectable metastatic disease at the time, we aren't really going to be able to steer the ship differently. And then finally, this trial was looking at the impact of an early intervention on recurrence rates. Just to be very quick about this, the study was looking at measuring ctDNA at every 6 months using the Signatera assay, so that's the Natera assay, and patients who participated had to have been receiving endocrine therapy for at least 6 months, but less than 7 years, and they had to have some marker of having some level of high-risk disease. You can see these things that are listed here, so more than 4 positive nodes. If they had a 1 to 3 positive nodes, they had to have a high-grade tumor or a larger tumor. Patients, if they were found to have ctDNA on this surveillance screening, they underwent systemic imaging, and if imaging was negative, then they were randomized to continue on the same adjuvant therapy that they were on versus switching. In most cases, that was an aromatase inhibitor versus switching to fulvestrant and palbociclib. For the sake of time, I'm just going to go on to look at this consort diagram just to help people kind of walk through this, that the trial started enrolling and started to screen patients, 585 patients. And then in order to develop the Signatera assay, there has to be tissue available from a patient's primary tumor to create this molecular signature. So that after they ruled out the patients, they couldn't find tissue or there wasn't available tissue, they were able to begin CT surveillance on 570 patients. And what is really remarkable is that in this high-risk population, 447 of these 507 patients had ctDNA that remained negative. So even in a high-risk population, the rate of finding positive ctDNA was low, only 60 patients. And then a number of these patients excluded for various causes or reasons. And most importantly, 16 out of those 60 patients, or 27% of patients, when they had their imaging, already had radiographically detectable metastatic disease. So they were left with 38 patients that they could randomize. So remember, they started with almost 600 patients screening to come up with this question, to answer this question: what if we change therapy, keeping patients either on their standard endocrine therapy or switching them to an alternate endocrine therapy? So each of these arms was very small. This just shows the number of cumulative number of patients with positive ctDNA. And you can see here that this is topping out at less than 15%. So the median number of tests that patients had was 5. The follow-up time was 29 months. And among these patients, remember, there were 60 patients that had positive ctDNA. 37 of them were positive at the first screen, and 23 of them tested positive after 1 or more initial testings. The important thing to look at on this very busy slide is really looking at those patients that had ctDNA negative on their first screen, so 465 patients. And with about 29 months of follow-up, only 5% of these patients had cumulative molecular relapse. And then looking at the patients that remained ctDNA negative throughout their entire screening, only 0.5% of those patients, or 2 out of 442 patients, were diagnosed with a clinically detectable recurrence, so meaning they had a positive scan. So basically what this tells us, that this test has a very strong, a very powerful negative predictive value, meaning that if you get a negative test, it's very highly likely that you do not have a metastatic recurrence. This just shows what happens to those patients who were on the various arms, the arm where they were randomized to get switched over to fulvestrant and an aromatase or a fulvestrant and palbociclib versus staying on their endocrine therapy. So some of those patients that had positive ctDNA were able to clear or reduce the amount of circulating DNA. And you can see that on the left side of the screen, that was higher in arm A, those patients that were switched over to the alternate endocrine therapy. So this kind of goes along with what we saw with the Serena. You can imagine that, an early introduction of a new therapy with some sort of subclinical measurement of progressing disease may be beneficial, but these were a very, very small number of patients. This arm A only had 16 patients. This is what happened in terms of the patients that had ctDNA clearance. That among those patients that had positive ctDNA and then they actually cleared it or decreased it, a much smaller number of them, 1 out of 9, ended up having a clinical relapse. Whereas those, meaning that they had a scan that showed that they had distant metastatic disease. Among those patients that had increasing ctDNA over time, so in other words, with the intervention or with further follow-up, their ctDNA increased. 6 out of 10 of those patients ended up having a clinical relapse. The important takeaway message I want to mention here is that it's 6 out of 10, not every single patient that had increasing ctDNA had a clinical relapse. And this is a really important question that I bring up to my patients is that while it seems very appealing to know that you have this test and you want to do something about it, there still may be a small number of patients, in this case, 4 out of 10, who had detectable ctDNA who had not yet experienced a clinical relapse. So that's a lot of anxiety when we don't know what the right thing to do is for those patients. So just to be very, very brief about this, the takeaway messages were that 12% of this study of almost 600 patients were found to be ctDNA during surveillance. So I consider that to be quite a low number. And I think this is very important because this trial was focusing on high-risk patients. So I have patients coming in to talk to me who have a 1.5 centimeter ER positive grade 1 cancer, node negative. They would not have been included in this trial, and these are not patients where I feel like we should be using this technology, and I feel like we really need to be very selective. It is, in my mind, still not ready for prime time. Out of those patients, 73% of the patients that were ctDNA positive were imaging negative, meaning that 27% already we had detectable metastatic disease. And then 86% of patients experienced or developed their positive ctDNA test after an initial negative test. So serial surveillance does matter. And then, as I mentioned, in this trial, there was a very, very small number in total, a small number, only 38 patients that were agreeable to be, 34 patients that were assigned or randomized to get either continuing on their same therapy versus switching, and switching did seem to help and matter, but this is still, we had to screen a lot of patients to come up with a randomized trial to show an intervention. And I should mention in the triple negative setting, a similar trial design was undertaken looking at ctDNA, and the trial was actually aborted because by the time the ctDNA test was positive, in the triple negative population, a very high percentage of patients already had radiographically detectable metastatic disease. So there's an effort to sort of refine these tests to try to improve the positive and the negative predictive value. Thankfully, it seems like this test does have a very, very powerful negative predictive value. So a negative test is very important, is very reassuring, but we still have some to learn about what a positive test means. So I'll pause there because there's so much to talk about.
I
Again,
know
this could be a
this
whole
is a huge
session.
topic, and I know we don't have time to do it justice, but let's just do a quick lightning rounds of Michelle. So I think you already said this, like, do you send ctDNA or a Signatera in the adjuvant setting?
Yeah, I try not to. I mean, of course, we have patients that come and there's another center, in our city that's as participating in a sort of a pragmatic trial and are, sort of selling this. The company is selling this to patients very, very hard. And I really, we have trials open, and I feel like this really still, we need to continue on with research and try to collect more data. There are rare circumstances where if I have a very, very high risk patient who maybe has an equivocal finding on a scan, maybe a pulmonary nodule that we're following or something like that, then I might order it. But it's more the exception than the rule.
Okay, how about you, Hemali?
That's same for me. I don't routinely obtain the ctDNA monitoring in the adjuvant setting, except if somebody's in a trial or, if there's like a rare clinical scenario of we're trying to address a question that we can't biopsy, and then we're utilizing one other data point to add to our assessment.
And Rita, even though you're a surgeon, you could still order it too. Would you?
When the medical oncologist says no, then I order it. No, just kidding. That's a joke. That's a joke. No, I typically no. I do have a handful of patients who are getting the test serially, and it is very interesting because I can think of some patients, actually a couple of patients where the test is positive and we get scans and there's nothing, and so we just keep looking at these positive tests every few months, and so I think it's really hard to know what is the right thing to do.
Yeah, I mean, I think, Rita, you and I share a patient that has had a positive test for 2 years, and we're scanning her and no evidence of disease. And I think that, thankfully she's a very calm person. And I don't know how many patients could actually tolerate living through this, So I think you have to be very clear with a patient, that we don't really yet know what to do with the data. And it's so important, to also mention that these interventions that we're talking about, like the oral SERDs, I mean, they are not yet available in the early stage setting outside the context of a trial. So we can't get these drugs that patients are getting in these trials for you if you have early stage disease. And so it's unless we lie and say that you have metastatic disease, if you have a positive test and a negative scan, we can't get you the drug.
And how about you, Laura?
Yeah, I agree with everyone. I think until we know what to do with it and we know that it improves outcomes, why send a test that's not going to help patients? I'm hoping we get there in our career, and a lot of these trials will help us figure that out, that if we can change treatment and avoid metastatic disease, obviously that will be a game changer. But I think we're at this point right now where we don't have that data yet. So it's why send it until we know what we do with it.
Yeah, and I agree as well. And I guess I just want to close this with an acknowledgement to all the patients, which is that the current field, the state of the field in this setting is inadequate, in my opinion, right? Because every single patient wants to know, how will I know that if my disease is coming back? How are we going to catch it early? And our answer is completely unsatisfactory to us, which is, well, we don't do scans because that hasn't been shown to improve outcomes. We are waiting for a symptom, right? And we know that by the time there's a symptom, then it's a metastatic recurrence, and we can't intervene to change that course. And the reason that we haven't done nothing has been approved in this space is because of old studies that have looked at tumor markers, blood tumor markers, or CT scans. And we, at that time, there were no targeted agents, no effective therapies. But if we can, there is a technology that can detect recurrence early enough, whether that's through blood with sensitive assays, and we have effective targeted therapies now. I think if we do those trials, then we can hopefully find something that we can use to intervene early and actually cure more patients. So I want everyone to know that when we say we're not ready to send it now, it's not because we don't want to and we don't see the urgent need for this. It's that we don't know how to intervene to actually improve outcomes, and it can lead us down wrong paths. But it is something that I believe will happen, hopefully in the near term. So with that, I want to save enough time for Dr. Mukhtar. She's going to present some really exciting data that she actually has led and that I has played a major role in. And if those who can stay on longer, because this may go beyond 7:30 just a little bit, just so we can hear this data, which is really exciting. So Rita.
Yes, thank you. So, all of this discussion about ctDNA has really been about predicting who might have a recurrence or who might benefit from a particular medical therapy. But I think that there is a potential role in helping us plan what kind of surgery we do and maybe improve our ability to do the right surgery for patients. And so that's the idea behind these data. And the data that I'm going to show are from the I-SPY trial. The I-SPY trial is a neoadjuvant chemotherapy trial. So for patients who have stage 2 or 3 breast cancer, and the tumor is mammoprint high risk, so predicted to benefit from chemotherapy. Patients are randomized to various different types of chemotherapy, and then the primary endpoint of the trial is the rates of pathologic complete response, meaning you go to surgery, the area of the tumor is removed, lymph nodes are removed, and then seeing if there is any invasive cancer left. But what I want to start with is how do we currently do our axillary surgery for someone with non-metastatic breast cancer? And many of you may know that we typically will do what's called a sentinel lymph node biopsy, so removing between 2 and 4 lymph nodes. This also can be called a targeted axillary dissection if you are targeting a specific node by placing a clip in it. And if someone has any positive node after receiving chemotherapy, then they are supposed to receive an axillary dissection, and that removes the majority of lymph nodes in the armpit area. And unfortunately, removing so many lymph nodes can be very detrimental. So it can cause swelling of the arm or lymphedema in up to 40% of people who have this procedure. So if we think about why we do this, or if we should be doing this, let's look at like 2 potential scenarios. So this graphic, the red is showing a lymph node that has cancer in it. But keep in mind that this does not always show up on imaging or on physical exam. So we don't know that there's cancer in these lymph nodes until the nodes have been removed with surgery. So if a patient had cancer in lymph nodes like this after chemotherapy, they would get sentinel lymph node surgery. It would remove, say, these 3 nodes. 3 out of 3 would be positive for cancer. So then they would be told they have to have an axillary dissection. So then they would have the rest of the nodes removed. In this case, they would have 4 more positive nodes, and so many, many positive nodes. But if you consider a scenario like this, in this scenario, the sentinel lymph node surgery would show 2 out of 3 positive nodes, but we don't know how many more positive nodes there are. Since at least 1 had cancer in it, we are supposed to go back and do the full axillary dissection. But in this scenario, that would be removing 8 more nodes, all of which were negative. So this person ended up having a bunch of lymph nodes removed that were completely normal. So that surgery is giving a lot of risk to the patient with no real benefit. Unfortunately, this actually happens quite often. There is an ongoing clinical trial testing whether or not we can do radiation instead of full axillary dissections in situations like these. And in that trial, what they found is that for people who have at least 1 positive node who go back and have the rest of the nodes removed, more than half the time, the rest of the nodes were normal, but we just didn't know it until they were taken out. So the question is, can we use ctDNA to try and predict whether or not we're going to find more positive nodes if we go back and to do the full axillary dissection? So on the I-SPY trial, patients get ctDNA tested before, during, and after neoadjuvant chemotherapy. And what we did was we looked at whether the ctDNA was positive or negative at the beginning of chemotherapy and after chemotherapy, and then we looked to see how many positive nodes patients had. I'm going to skip over the patient characteristics, but there were 493 patients that we ended up analyzing. And I will just briefly say that in the I-SPY trial, 70% of the patients were ctDNA positive, but cleared the ctDNA after neoadjuvant chemotherapy. So we took all of these clinical features, the size of the tumor at baseline and at the time of surgery, the hormone receptor status, the HER2 status, the ctDNA. We took all of that information and we put it into a machine learning model, which is a form of artificial intelligence or AI. And we asked the model, can you split these patients into groups? So a group that has a low chance of having many positive nodes and a group that has a high chance of having many positive nodes. And then tell us, what are you using to group these patients? Is it the hormone receptor status? Is it the ctDNA test? And so on the next slide, I'll show you the groups that the machine learning model identified. And it's many different groups. It's 12 groups. And so I'll show it to you in different parts. So this is the first set of groups. So the model identified that patients who started out with a positive node, so they're clinically node positive, but their circulating tumor DNA was negative after getting chemotherapy, the blue bars are showing how many of them had a high number of positive nodes that would need an axillary dissection. And that ranges from 6% to 15%. The next set of patients are patients where they were also clinically node positive at the beginning of chemo. And then after chemotherapy, their ctDNA remained positive. So they did not clear their ctDNA. And the blue bars are showing the proportion of patients that had many positive nodes, and that ranged from 30 to 60%. And then the final group were patients who were clinically node negative. So they did not have any positive lymph nodes that we knew about before starting chemotherapy. And then in the blue is showing how many had many positive nodes at surgery. That ranged from 1 to 10%. So the blue bars are showing this range where instead of saying, okay, it's a 50-50 chance of knowing if this person has many positive nodes or just a few positive nodes, now we can kind of refine that better and go down from 1% all the way up to 60%. And then the orange bars are showing how many of these patients actually had the full axillary lymph node dissection surgery. So many patients are getting full axillary lymph node dissections, even though they only have 1, 2, or maybe 3 positive nodes, or maybe no positive nodes, which we could have just removed with the sentinel node surgery alone. So the idea here is that the ctDNA does help us split patients into groups. And then this is just demonstrating again, like in a, maybe a simpler fashion, that you can broadly say that someone who has no positive nodes before chemotherapy, or they had a positive node, but their ctDNA became negative, those patients, the chance that they have many positive nodes is between 1 and 15%. If the ctDNA remains positive, then it's a really high chance that they have many positive nodes. And then the one exception to this rule is that for patients who started out with large tumors that were hormone receptor positive, even if they cleared their ctDNA, that particular subset still had a 30% chance of having many positive nodes. So, so these data, I think, is like the first time that we're looking at ctDNA to maybe decide what kind of surgery would be the best for a particular patient. Definitely not ready to be actually used in clinical practice. This will need prospective validation, but I think showing another potential use of ctDNA. And then I think I'll stop. I was going to briefly talk about the endocrine optimization study, Joe, but I can just pause here, and if questions come up, we can discuss that.
Great. I think this is so novel because, you know, as you've heard, there's been a lot of presentations about ctDNA for systemic therapy in the metastatic setting, but I believe this is one of the first, if the first, using ctDNA to make surgical decisions on something that gives patients a lot of morbidity. Axe dissections increase the rates of lymphedema, upwards of 30% for some patients. And so this, I think, would be a huge clinical advance. Rita, is this ready to be used in the clinic?
I don't think that it's ready to be used in the clinic. You know, these are retrospective data. I think that what our next step really is to validate this in a prospective fashion in the I-SPY trial. And but I think that it can maybe, you know, I think it can help inform how aggressive we should be with our surgical planning.
And do you think that this might have particular use for patients who have lobular disease, for example?
I think it's a very good question. I was a little bit disappointed to see that the one group where the ctDNA result didn't work so well for predicting how many positive nodes were patients who had hormone receptor positive large tumors. And that is often how lobular breast cancer presents. It's usually hormone receptor positive. And because it is not caught on mammograms very well, patients often are diagnosed at later stages or with larger tumors. So I think we have to look more closely at that, but it appears to work best for patients with triple negative and HER2 positive tumors.
And we did get a question in the chat just asking about the EOP update. And of course, that is a soft spot in my heart, my own heart. So can you give like a two-liner on what you were going to say about the EOP update?
Yes, so the EOP, I mentioned that I-SPY 2 is for patients whose tumors are mammoprint high risk. But of course, there's a huge need for patients who have stage 2 or 3 breast cancer that's mammoprint low risk, who we also would want to try to shrink the tumors before surgery and figure out whether or not the tumor is going to respond to non-chemo-based treatments. So the endocrine optimization pilot is a way to give novel endocrine therapies, including some of the SERDs that were talked about earlier, like Vepdig, in combination with other medications, and to see whether or not the tumors will shrink, to see whether or not decisions might be, we could maybe use the information of from the response to decide what to do after surgery, and also whether we can improve the surgical outcomes. So EOP is accruing very well. This is actually Dr. Chien is the PI of the EOP study, so you should be giving this update. Over 200 patients enrolled. Several of the arms actually are fully accrued. We're expanding, going to be adding in new drugs. Also looking at ctDNA in the endocrine optimization pilot. A smaller number of people in the EOP study are ctDNA positive than in the chemotherapy part of I-SPY. But interestingly, a good number of people are also clearing their ctDNA from these novel endocrine-based treatments. So that's definitely something that we're looking at. And that data was presented by Silver Alkavaji, one of our PhD scientists here at UCSF, gave a talk on that at ASCO.
Excellent. Thank you. Well, what a whirlwind. I think we covered a lot tonight, spanning metastatic and early stage. A lot of excitement with ctDNA. As you can see, I think it's here. We just need to figure out what the clinical utility is. And lots of potentially practice-changing abstracts with new agents being used in the first-line setting, improving progression-free survival, potentially improving progression-free survival too. And then this idea of potentially using molecular progression for therapy guidance. So not yet ready for prime time, but we're getting closer and closer. So really exciting. Thank you so much for joining us tonight. Stay tuned for dates for the next forum. Please email us with questions and/or topics that you're interested in, and we will see you next time. Thank you so much for joining.